Good evening, everybody. I want to thank all of you for coming out on a Thursday night to learn a little bit about what we're going to talk about tonight. I see some familiar faces. I have several patients in the audience, and I see a lot of new faces, so I'm excited to share some of what I have to talk about. The topic, obviously, tonight is talking about voiding dysfunction, which is a big problem for people. To give you a little bit of background, I'm actually a cancer surgeon. That's my specialty training. And I've been practicing medicine now for almost 20 years, and I've been a robotic surgeon. That's actually what I just came from doing. I did a bunch of robotic surgeries today. But when I came out of my training and I was raring to go and do cancer surgery, when I first started practicing, I realized that even though urologists are supposed to take care of problems with urinary issues, many of us are focused on bigger issues, things like cancer or kidney stones or enlarged prostate. And for some reason, a lot of the people who suffer from the day-to-day problem of having leaking, whether it's urinary leakage or sometimes bowel leakage, these things get kind of swept under the rug. And people often don't talk about them, they don't take care of it. And when I started practicing, I realized that it was very important not to just be focused on the thing that you do in terms of your specialty training. You really need to work on the little things. And an example of that is incontinence, and we're going to talk a lot about that tonight. I'm going to walk around a lot because I don't have my slides in front of me, so they're up here, so you'll see me wandering around. Let's get going. That's me. So we're going to talk about multiple things, but the bladder is what we're going to focus on. And the biggest thing that really comes to mind when people see me in the office is just the intrudence that it causes on people's lives. They don't want to go out if they're going to have an accident, or if they have to know where all the bathrooms are, or if they have to leave in the middle of a movie, or if they have to, be at church and get up in the middle of the, father's or pastor's sermon. It's just kind of a difficult thing to have to deal with. So, this really guides people's lives, and it gets to the point where they sometimes just don't go out because they're worried they're going to have issues in these departments. So, we focus on the fact that people say, as you get older, you're going to have a lot of urinary problems. That is not true. It is not normal to have a lot of these problems. We can fix these problems. And some of you in the room have come already to see me to fix these problems. And I hope many of you will come see me if you are having these problems. So it's not normal just because you're getting older to leak. It's not, just because it's part of being a woman. I hear that one a lot. And then prostate issues from the men's side. And obviously, I did something and that's why I leaked. None of this is normal. So we're going to talk about how we fix it. So in terms of quality of life, I just went over some of these things. You don't do physical stuff because you think you'll leak. You don't want to go to church. You don't want to go to social activities. You feel like very, very bad about yourself if you have these problems because you think I'm weird and everybody else is fine. And trust me, this is a very, very common problem. So it's not just any one of you. And it's also very impactful on people's relationships. So if you're intimate with your partner or husband or wife and you're having problems with leaking, it really can affect both your confidence and the intimacy in your partnership. People also have to spend money on pads and diapers. That's a big thing that I hear about every time someone comes to see me. So I want to just re-emphasize the point. This is not you. This is a very, very common issue that we're dealing with, and we need to talk about how we fix it. So we're going to talk about a lot of different things. There's a bunch of safety stuff. Nothing that we would present today is not safe. So even though the people from Boston Scientific, which is the company that is kind of supporting this and organized this, I want to give a quick shout out to them for helping us to get this done tonight. Their therapy is called axonics, and we're going to spend a lot of time talking about that. So, look at these numbers. And this is the top number is that 50 million people in the United States. There's about 370 million people in the United States. So basically 1 out of 7 of those people suffer from some type of urinary incontinence, which is just an obscenely high number. And that's who we actually document. So many people have the problem also and just don't admit to it or want to put it on paper. And then on top of that, there's an even more difficult issue, which is bowel or fecal incontinence, which many people suffer from. It's very common to have over the age of 70, and people are very rarely asked about it and don't want to talk about it. So that's an even bigger problem that we have. And so when we think about these problems, we want to try to find a way to address them with a treatment that will help both problems. And that's one of the things we're going to talk about. So the things that let's talk about what we commonly see. Who here has heard of the term overactive bladder? Raise your hand. And so overactive bladder is a very general term, but it basically means you have to run to the bathroom really suddenly because you think you're going to lose your urine. You have to go to the bathroom very frequently. Sometimes your bladder just lets go when you're doing absolutely nothing. So you're not doing any physical activity, you're just sitting there, and all of a sudden the bladder decides it's going to go. That's why we call it overactive. And that's something that really is a problem for many, many people. Urinary retention is a separate problem. That's when you can't go. So we often have patients as they get older, if they've had pelvic surgery, if they've had prostate problems, sometimes they have neurologic conditions like MS, or they've had a stroke. Another example makes it very difficult to empty your bladder. So urinary retention is a problem. And then fecal incontinence, which you'd think that a GI doctor or someone who specializes in the colon or intestine would be taking care of this, but believe it or not, urologists spend a lot of time taking care of this issue. And why? Because it gets uncovered when we talk to them, to talk to patients about urinary incontinence. And when we ask the question of if you're having issues with your bowels, it comes out because most people don't ask the question. So what does the bladder normally do? The bladder is a muscle, so it's got 2 jobs. One is to stretch and fill with urine, and the other is to actually contract and empty the urine. And so the normal phases of urination are called storage and emptying. And basically, for everyone, when you're younger and then throughout life, you think to yourself, okay, I go to bed at night. When you were younger, you probably didn't wake up to empty your bladder, but as you get older, you find that you wake up a few times. And that's a change that happens that we see in both men and women. But when we judge kind of like what the normal status of the bladder would be, it would be the bladder fills up slowly over the hours that you sleep, as an example, and then in the morning you go into the bathroom and you empty your bladder completely. That's what we want to see. Many people don't have that current situation, and that's what we're going to talk about trying to fix. So the things that we mentioned before that go with overactive bladder, we're going to split these things up. So frequency. So I'm gonna just give the audience a couple of choices, like in terms of what do you think the normal time should be in between urinating during the day. Raise your hand if you think it should be 1 hour in between urinating. Raise your hand if you think it should be 4 hours. Okay. Raise your hand if you think it should be 2 hours. Okay. So the actual answer is that it's 2 hours. So most of us actually go longer than 2 hours, but everything in life is on a bell curve, which basically means, some people are a little bit more frequent in terms of the time that it takes them to urinate, and other people, go longer. But the average, what's considered normal, is 2 hours. So if you go more frequently than 2 hours, that's when we say that you have urinary frequency. The urgency that I talked about before doesn't really have a right or wrong answer. It's just we gauge it on a 1 to 4 scale. So 1 is, I gotta go, but it's not so severe, I can wait to find a bathroom. And 4 is, oh my goodness, something just happened, I just had a leak. And then there's everything in between. And then urge incontinence is the number 4 that I just described, where you basically just do not have a chance to get to the bathroom. You get an overwhelming urge and you've already had an accident before you can do anything about it. And then the last thing, which is a very problematic issue for people, is waking up at night. Again, let me ask the question. You can just throw out some answers. What do you think is the normal, like in adult age, what do you think is the normal number of times that someone should wake up at night to urinate?
0.
Yeah. I would like 0. It used to be 0.
Then 1.
Okay, so it's usually less than 2. And anything over 2 we consider to be too much. And I have people coming to see me. I had somebody that I saw a couple days ago that was going like 12 times a night.
Oh my gosh.
And if you go 12 times a night, you can't get any sleep. And what happens is, and that's why the waking up at night to pee is such a big issue, even if you don't have those other problems, if you can't sleep because you have to wake up so much, then that person really didn't have a very happy life, because they were napping all the time during the day. They couldn't really go out, and they were just very unhappy with their symptoms, so they want me to fix it. So fecal incontinence, that again is something that no one in any medical office that I can think of routinely asks about. You go in for a checkup, it's just not a question that comes up. It's obviously not something you talk about at a restaurant with your friends or at church. These are, and it's a very, so I'm gonna tell you a number that's gonna blow your mind. So if you're raise your hand, you don't have to do this, but raise your hand if you're over the age of 70. Okay, so 35% of people over the age of 70 have fecal incontinence.
I think you're under 70.
The number's a little less, but the number climbs as you get older, and it's related to, yeah.
Still.
But if you think about that, it's 1 out of 3. So imagine that you're out with people, you go out to dinner, you're out with people your own age, and that never comes up, but yet 1 in 3 of the people, and that accounts, that equals several million people in the US have this problem. And many of them, when I just said you go out to dinner, the truth is you probably won't see those people because they don't go out to dinner. They're the biggest shut-in people when it's a very severe problem. So those are the kind of people where they have to be asked the question, what's wrong? Like, are you having this problem? Because somebody's got to ask the questions that other people don't want to ask. And so that's what we try to do, because this is a fixable problem. So in terms of, we talked about how the bladder works, the bowel function, the rectum is the area where the stool is stored, and then the intestine basically is the passage of nutrients from when you eat. We absorb nutrients, we absorb water, and then you have stool. And basically you have to have some coordinated responses of your muscles in the pelvic area, which is the same actually for urinary symptoms. So that's why they're kind of related. And believe it or not, the muscles that hold your urine in, the nerves that control your urinary control are the same that are responsible for the bowel. And that's one of the reasons we're talking about this tonight, because we can influence both of the problems by talking to the nerves that control these systems. So, yes, there are treatments, and some of you have talked to me about these before. Some of them I've done on you, and other people don't know about this and they need to learn. So I think this is probably, we're going to have time for question and answers, and I'm going to explain a lot of things, but the number one answer to every question is if you have a problem, there's a pathway that we work through that helps you to figure out how to solve it. And I want you to remember that, because if you don't want to talk about it in this public setting, I want you to come to my office or one of our providers' offices, because these issues can, we almost always can fix these problems. It's just not something that we can always get to from a Q&A at a seminar. So this slide's very important, because the pathway, we put you on a pathway to figure out what's wrong, and then we come up with a plan for how to treat it. So when we do initial treatments, like for these, there's 3 problems up here. I'm going to use the little pointer. Is that working? No.
I don't think it works, Dr.
Oh, okay. So, so we have the overactive bladder problem, we've got the urinary retention, and we've got bowel leakage. The reason I'm talking about this treatment called axonics therapy tonight is because that therapy basically fixes all 3 of those problems, and they're very different problems, but because I mentioned before that the nerves are the same, that's why we can influence the nerves to control these problems. And it can work if you have just one of the problems, it can work if you have all of the problems, or anywhere in between. We don't just jump to things, you're gonna learn a little bit about what this is, and I'll explain it, but we always go with the easiest solution first before we jump into more complex things. So most people who come to my office with any of these problems, the first thing we ask is, well, what are you doing to change your behavior or do exercises? So an example would be if someone comes and tells me that they're waking up 4 or 5 times a night, one of the questions I'm going to ask is, well, what are you drinking, before bedtime? And sometimes the answer is, well, I have a couple beers, or I have like 3 cups of coffee, and I do that about 2 hours before I go to sleep. And I tell them we should probably stop that, and try. We should probably try to cut down what you drink at night, and that's called a behavioral modification. It's changing your behavior to try to improve your symptoms, and sometimes that works. And for other people, it doesn't. And then we move into other options. And there's 2 that come to mind. Obviously, many of you have, if you're having these issues, have probably tried medication. Your primary care doctor sometimes put people on medication. Sometimes it's urologists, sometimes it's gynecologists. The medicines work in different ways to control these problems. The problem is many of them have side effects, which are kind of well known. People have dry mouth or constipation. Sometimes they have blurry vision. And as people get older, they can also affect how you think. So the medicines are good because they're non-invasive and they're easy, but they can also have some negative qualities to them. There's also something called pelvic floor muscle training, which is a really good thing. We have, Good Shepherd has a really good physical therapy program. And as I mentioned before, in order to urinate normally, you have to engage your pelvic muscles. And in order to have a normal bowel movement with good control, you have to also use your pelvic floor muscles. So it kind of goes in line to think of that if you get appropriate, exercise of those muscles, that you're going to see improvements in those areas. The problem is that you can only exercise those muscles so much. So we use that kind of as a correlate to other things that we do. It can improve the situation, but it's not necessarily going to fix all those problems. But I would very much encourage you to talk, if you haven't considered the idea of pelvic floor therapy or physical therapy, it's a good idea to bring up with your primary care provider if you haven't already seen a urologist or a GYN to talk about these problems. When you get into advanced, the bottom says advanced therapies, and that's what this is, and we're going to talk a little bit about that. People do these therapies when they've tried, usually it's multiple medications, so typically we try people on at least 2 medications. We do things like physical therapy for them. We do behavioral modification. We have them cut out the coffee and the alcohol or other things that can irritate their bladders or their bowel. And then when all of that hasn't had success, that's when we talk about axonics. So there's something called PTNS, which stands for posterior tibial nerve stimulation. And this is kind of a way to test for this. I don't do this anymore because I don't think it's as effective, but I did want to mention it because it's done in a lot of different offices. Kind of, there are people around the Tri-Cities area and not far from here where they use this. The idea is for this treatment, it's sort of like an early test to see if we can talk to those nerves that I'm going to tell you about. And what we do is the nerve that goes in you have a nerve running down your leg to your ankle, and you can actually put a little probe on your ankle and stimulate the nerve going up the leg, and that talks to what's called the posterior tibial nerve, which leads into the nerves that I mentioned before for the bladder and the bowel. And you can actually, over time, sort of change the behavior of the nerve to help control your symptoms. And what's interesting about this is people, it reminds me a lot of people who go to, the barber shop weekly. So they come and sit in a chair and they get this little thing put on their ankle and they sit there for about 30 minutes, and there's often other patients who are there all sitting in their chairs, and they talk about, the weather or sports or whatever, and it's like a weekly activity. And over time, usually you do this like 12 weeks, so once a week for 12 weeks, we can see some changes in both urinary and bowel symptoms. The problem is that it's not long lasting, and you got to keep going back. So we find that the people that usually keep going back are the ones that kind of want to just talk to the people and like hang out. So it's not a bad therapy, but I don't think it's the best. Who here knows what Botox is? Okay, not for your face, not for your forehead. So Botox it's called botulinum toxin, and it basically is a chemical that paralyzes things, but it only does that temporarily. So when I mentioned before that in the bladder, one of the problems is that you get an urge to go, or your bladder's firing when you don't want it to. They found out about 15 years ago that you could inject some of this Botox into the wall of the bladder, and that would temporarily kind of paralyze, not the whole bladder, but portions of the bladder, and that would relieve some of the symptoms. And that's something that we've done in our office before, and some of you who have come to see us have had it before. What I don't like about it is that it's more of an art than a science. So we've had people put too much in, and then because the idea is you're paralyzing the bladder, if you paralyze the bladder too much, then the bladder stops emptying urine. So then you have to have a catheter or some way to empty the bladder for a couple of months until it wears off. So that's one negative about it. And then the other thing is just that you're sticking tiny needles in we use a scope to do that inside the bladder, and you have to repeat that process. So because the Botox wears off, so just like it wears off in people's faces for cosmetic reasons. So you have to repeat it every 3 to 6 months, and after a while, that process gets kind of tedious for people, and it also can cause some scarring in the bladder. So even though this is something that works, it's not our favorite treatment for that reason. Now we're going to talk about axonics. So what axonics is something called sacral nerve modulation, which is a fancy term for overriding the connection. You have a normal connection between your brain and your bladder, and between your brain and your bowels, that helps to control how you urinate and how you defecate. When that when that pathway is kind of disturbed or not working properly, that leads to the things that I showed before, like not being able to empty, having to go too frequently, waking up at night, having leaking, all of those issues, and then also bowel leakage as well. So we figured out, who here knows what a pacemaker is? Okay, so a pacemakers were invented about 60 years ago. And they were initially designed basically for people who had a heartbeat that was too slow, and they would pass out and sometimes die. So what a pacemaker is a little battery that's put in up here with a little wire. It's under the skin, and the battery has a sensor that allows the heartbeat to be monitored and then sped up to the right speed, and that keeps people from passing out. About 30 years ago, they figured out that you could use that same concept to control the bladder, and that's what sacral nerve modulation is, except it's not done in the chest, it's done on the backside back here, and we'll talk about where those nerves are. And then very soon after they figured out that it would work for the bladder, they found out it could also work for the bowels. They didn't know when they first started doing it, and then they actually had patients say, oh, you know what, by the way, I was having accidents, I didn't tell you about them because you didn't ask me. But those stopped going away, those stopped happening also. So, okay, so let's get into, okay, so these are examples of the implants that we put into people. And the most common implant, I mentioned pacemaker before, the one on the right is called the F15. And we basically don't put an implant into someone without knowing if it works. And I'll explain what I mean by that in a minute. But that little device is about the size, I don't have my little pointer, but it's about the size of a silver dollar. And it's a little bit thicker, and it's implanted under the skin. And it's designed to basically take on the role of controlling the bladder and controlling the bowel for people who have these problems and don't respond to the medications and the conservative treatments that I talked about before. So what are we actually doing? So I'm going to walk you through that process. If you've been in my office, you may have heard me do this before, but I'll kind of go through it. So the nerves to your bladder and your bowel actually run not in your spinal cord, but in your tailbone. So kind of, if you picture where you sit at the tip of your tailbone, you have two openings, one on the left side and one on the right side. And there are nerves that run from your spinal cord, and then they come outward like a tail, like a horse's tail. So it's down out to the left and out to the right. And we actually have a way to talk to those nerves without putting in an implant. And we consider that like a test drive, like you're buying a car and you don't want to, take the car off the lot for permanently until you know that you like it. So we bring you to a place where we can see your tailbone with an X-ray machine. We usually do that in an office. Here we've been doing that in a suite in the operating room, and we're going to be doing that in our office very soon. We basically put you on a table, and we use pillows underneath you so that you're comfortable. And we look at your tailbone with an X-ray machine. So we're looking at this area right here. And I can see the openings for where those nerves go on that X-ray machine. And I'm able to, using the X-ray machine as a guide, put two tiny little wires, which are about the thickness of one of my hairs, one on the left and one on the right. And then I start stimulating the nerves. And there's two things that happen when we do that. One is you feel something, and the other is I make you do something. So in terms of what you usually feel some stimulation down in the pelvic muscle area in the front. And then in terms of what I make you do, I make your big toe go up and down like this. So when it works and it's in the right spot, you'll go whoop, and the big toe comes up, and we know we're talking to the right spot. So we're then able to know that we're talking to the correct nerve. And so just to rehash, what is that nerve supposed to do? It's supposed to control overactive bladder. So we talked about that if you're going too frequently, which is anything under 2 hours. If you're waking up more than 2 times a night, if you're having just sudden urges to go that you can't control, that's the urinary. And then also if you're not able to urinate. That's the interesting thing about this therapy, is that it can not only help you not urinate too much, it can also help people who can't urinate to urinate. So it puts the bladder kind of right in the middle. I use the example of, I don't know how many people play with their, if you have a computer, I'm not that computer savvy. When I have a problem, I always just unplug it and hit the reset button and turn it off, turn it back on, and hope that it goes back to the original settings. And that's kind of what this does. So it basically puts you back on your normal settings. In terms of the bowel symptoms, what it does is it helps to tighten the muscle that holds the bowels in, or holds the stool in, and it also relieves the urgency that some people get to have a bowel movement, which some of you may have. If you've ever been in a car and you have to have a bowel movement, you're like rushing to go home and trying to squirm around until you get to the bathroom. We've all been in that spot at some point or another. So these nerves are influenced by these little wires that we put in, and once we are talking to the right wires, we attach these little wires to a plastic throwaway pacemaker. And that looks like a little, trying to think what it looks like. It's kind of like, this is a remote control, but it's a little bit thinner than this, and it's flat and it's disposable. So we tape it onto your back, and at that point you go home, and we basically, what I'm doing when I put all those wires in, that takes about 10 minutes to do, but when you go home, that's actually when we figure out if this works, because for the next few days, you have this temporary device sending signals to try to control your urine and your bowels, and we get a real life opportunity to see if this will help you. The response rate to this, and why I love this therapy, why I do it, about 80% of people who have these treatments respond across all of those symptoms that I talked about. So if you urinate too frequently, you will have usually about an 80% likelihood of getting better. If you don't urinate normally and you're having to use a catheter, you have about an 80% chance of getting improvement in that. If you're having bowel leakage, which is, again, nobody wants to talk about, but it's a very frequent problem, about 80% of people see improvement in that. So that's a really high number, and it's a very easy thing to test. And so you go home for those few days, and you'll see in these folders that there are diaries, and the diaries are there to try to have you track what's happening so that we understand, is this helping you or not? The other thing that's very important is we have to kind of have an outside verification that this is working. So we don't want to just rely solely on one person. And so we have people that work with us from Axonics and also from our office who call every day and check to see how the person is doing and kind of verify, yes, is it helping you? Is it not helping you? If it's not helping you, we need to change a little bit of the way that we stimulate that nerve, so we have the ability to change it. It's almost like tuning into a radio station. So we can change it, turn it a little up, turn it a little down, and try to get it on the right station. At the end of the few days, you come back into the office, and those wires that I put in are just held on with tape. So there's not any surgery involved. It's just putting the wires in and putting some tape on. And you basically come in and we take the tape off, and those wires fall out, and the little temporary pacemaker gets thrown in the garbage. And then we sit down and talk, and basically you tell me or my colleagues how you did. And to me, this, again, the responses that I've seen in people with, for example, like the person that I mentioned who was urinating 12 times a night, he dropped down to 2 times a night. So that's normal. And he thought, he thinks I walk on water. Like, so, and that is a very common response for this type of treatment. So if we decide after we talk to you, or I talk to you, that you tell me that this helped you, and I look over all the information that you collected, and I look over all the information that my colleagues collected during the week that you were tested. Then we talk about the idea of putting in something called a permanent implant, which is this, this device here. So this is the pacemaker, not for the heart, but for the bladder and the bowel. You can see how small it is. It's in the palm of my hand, and it's very thin. So that, technology these days is amazing. You think about the first computers that were in the 50s that were the size of this room. And, this device lasts for 20 years, and it controls all of the aspects of what I just said, with no other source other than a little wire that goes down. So just technology. I love technology in medicine. I do robotics, as most of you know. And when I see things like this, it just amazes me to think not only where we are now, but where we're going to be going. We'll probably have little, eraser-sized implants in a few years that people will be able to use. But we put this in. It's about a 20-minute procedure to put this in. It's done with a little bit of sedation, similar to if you've ever had like a wisdom teeth done or a colonoscopy or something like that. So it's just twilight. And this battery lasts for 20 years. You can do all the regular things in life that you would normally do. You can go swimming, you can do exercise, you can go on a plane, go through security, you can get imaging done. That's a big question. Sometimes people ask about, they have bad knees or bad shoulders, or they need MRIs for their head, and you can get those things done when you have this. So for me, this treatment for many of these problems is really a godsend, and the patients love it. And so I do a lot of it. I do about 20 to 25 of these a month. I'm one of the busiest people in the United States that does this. And why? The answer is because I love to help people. So the more we put in, the better it is for the people suffering from these problems. This thing, just briefly, when we put it in, as I said, it takes about 20 to 30 minutes to put it in. It's put in either right here, under the skin, or right here, and it takes about a week to heal. And then people go, well, what do I do next? You put this thing in me. And we have this little remote control that basically is designed to be as simple as possible. We know people, one thing that we've learned in medicine is that if you make something too complicated, people aren't going to use it. So you have to have a very simple device that allows you to do something with this stimulation that helps to control these symptoms. So this basically just has an on and off button and an up and down button. So you turn it up a little, you turn it down a little, you turn it on, you turn it off. So it's really simple to use. Once you have that device in, you basically go home. We try it for a couple of weeks, set on the setting, and you're going to feel usually nothing, because if you've ever been in a room where a fan is on or you hear an air conditioner, you first are in the room and you hear that sound, and then we call it white noise. It basically goes away and you don't feel it anymore or hear it anymore. So you won't really feel anything, but it's working. It's controlling all these symptoms. And then you come back to our office and we adjust it if we need to help your symptoms. And as I said, you can do things like get MRIs. And look at this number. I mean, to me, like of the problems that I just said, things that would make people not want to go out, make people not want to be social, make people have to buy diapers all the time, make people, afraid of having accidents. 93% of the patients had really impressive results 2 years after we did this. So to me, that's what we're looking for, things that not just you do, but that they continue to work for a long time. So that's another reason I really like this treatment. And you can see, Would they do it again? That's the other question that I have. Because when I describe this to people, they sometimes think, like, what are you trying to put in me? I don't understand. And I get it. And that's why we do the test. Because you have to know that the symptoms are going to get better for it to be worth it to do something like some type of surgery. But most of the people who have these problems, if I tell them I can do a procedure that takes 15 or 20 minutes and make your life normal again, it's worth it. That's how I see it. And if if I do my job right, which I usually try hard to do, you get this number on the right, which is that 93% of the people who did this would do it again. And I think that's a really impressive number. And then I just, normally they don't talk about, in these slides, they don't always talk about the implant process, but I think that's a very important thing for people to understand, because when you look through it, you're looking through the brochures on the front, on the front page and in the pages to, behind it, and you don't really get a sense of what we're trying to do. But the simple answer is we're trying to reset your bladder or reset your bowel control so that you're normal. And I think, this is a great way to do that. So I've talked for a long time, and first of all, I want to just tremendously thank all of you for coming out and spending time with me tonight and learning about this. I know it's a tricky topic, but I also want to open it up for questions. For those of you that would like to ask questions, I want to remind you, if you are not comfortable about talking about whatever the issue is, you can grab our card, or we have some people in the back. You can make an appointment to talk to me. I basically am either doing cancer surgery or I'm doing this. So I have many openings to talk about these types of problems if you prefer a more private setting to do that. Well, once again, I want to thank, first of all, the great staff at the hospital for putting this together, and all the support that we got with the food and with the introduction. Thank you very much, and with just coordinating everything. We really appreciate that. And also, once again, to the Boston Scientific team that came here and really helped to organize this. We thank you very much as well. And I hope all of you, if you have a problem, don't be afraid to come see me. I can't promise you I can fix every problem, but I will make every effort I can to try. And I hope all of you have a great night, and thanks again for coming out.